You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal, Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I am Dr. Ann Cross, and welcome to Medscape's In Discussion series on multiple sclerosis. And today, we'll be discussing COVID-19 and MS. And first, let me introduce my good friend and guest, Dr. Scott Newsome. Dr. Newsome is the director of the Johns Hopkins Neuroimmunology Clinical Fellowship Program. He's co-director of the Multiple Sclerosis Experimental Therapeutics Program there and associate professor of neurology at Johns Hopkins Medicine. He's an international expert on multiple sclerosis, and he's also the former president of the Consortium of MS Centers. So welcome all, including Dr. Newsome, Scott, to this program. So first of all, before we really get into the nitty-gritty of discussion of COVID-19 and multiple sclerosis, I'd like to ask you, Scott, what drew you to this area of medicine, to neurology and then to multiple sclerosis?
Yeah, well, first off, thank you, Ann. I appreciate the invite to participate in this, I think, very important Medscape activity. I'll try to make this brief as possible. For me, neuroanatomy, neuroscience always caught my attention when I was much younger. But I think even more importantly, as you know, my mother had multiple sclerosis. And so as a young child growing up and seeing sort of how MS could affect an individual, the good, the bad, the ugly, that always stuck with me. And as I was going through schooling, I feel like that was sort of the crux of my decision in going into not just neurology, but to become a neuroimmunologist and focus on MS care. And so that's sort of the short of it. But I do feel like that my past experience really is what springboarded me to go into MS.
So you must have been really rewarded as new medications came out and you had your hand in some of it. And that must have been particularly rewarding for you.
Yeah, actually, it's a great comment because when my mother was diagnosed, there were no treatments available. And then finally, when the first clinical trials came out, she actually participated in one of them. And so, here doing a lot of clinical trials myself, who knew that I'd be doing clinical trials when I was a young child, seeing my mother involved in a clinical trial. And so that was, I think, a really good experience. And yeah, as more treatments became available, some of which my mother didn't have, the availability to get, it became quite exciting for me to see where the field was going and how I could play a little bit of a role in the world of new pharmaceutical therapies for our patients. And clearly we're very lucky, I think, nowadays than even just several years ago, where we have, over 20 FDA-approved therapies that I feel are changing people's lives for the better in MS.
Well, you've certainly played more than just a little bit of a role, but we'll move on to the topic at hand, which is multiple sclerosis and COVID-19 and the pandemic. And I guess I'd like to ask you, what are the top things you think have changed in your care of multiple sclerosis patients due to the pandemic?
Yeah, there's so many. I'll try to break it into sort of the early part of the pandemic, when we didn't really know much of anything, then, sort of the intermediate pandemic and where we are now. And so I think in the early part of the pandemic, when we didn't know how COVID-19 was going to affect our patients, including, is my patient at risk who has MS, forget about the therapy the person's on. Does MS in and of itself put someone at greater risk to have bad outcomes with COVID-19? And then you add on a therapy. I will say we were, holding tight on medications, not switching, I think, people to stronger therapies, even at the time where we felt maybe they needed to be, because we didn't know what would happen if our patient got COVID-19. Would they end up having a serious outcome? And then I think as some of the observational studies started to churn out information like the COVID-MS registry, the Italian registry, we started to learn a little bit more that, well, wow, MS in and of itself doesn't seem to put people at risk to contract COVID, or if they were to get COVID, to have more severe outcomes. Then, for me, I started to feel like, okay, let's get back into sort of the pre-pandemic way of treating patients where maybe we wouldn't hold back necessarily escalating treatment if it was needed. Of course, though, then we found out, oh, geez, there's certain classes of medications that may put people at risk to have more severe outcomes if they got COVID. For me, I had to backpedal a little bit to say, okay, well, now we have to look at the individual situation and say, okay, do we now need to look at treating people a little bit differently if we're going to escalate treatment? But I'll say probably the biggest factor here in my clinic is that a lot of our patients have not had the opportunity to do some of the non-pharmacological interventions like the physical therapy, the occupational therapy, things that I feel really impact a person's quality of life. And so that's been a big impact in my clinic where now that sort of latter part of the pandemic, now that we've learned as much as we have, trying to get people back into the physical therapist, aqua therapy, as long as, we feel that they're safe to do so. We've been utilizing telemedicine. So this is where I think telemedicine is quite helpful. And those patients where maybe they're at higher risk to have bad outcomes with COVID, we're trying to use telemedicine to supplement some of our in-person visits. And I think that actually has helped provide higher level of care for many of our patients. As we are right now in sort of that third stage of the pandemic, I feel like I'm getting back to how we were treating people pre-pandemic with some caveats. And I know we'll likely talk about, vaccines and how do we go about getting our patients vaccinated with certain therapies, and are we dose adjusting some treatments?
That was a really good point you made. Well, multiple good points, but one of them was the one about non-pharmacologic treatments and the fact that a lot of our patients and we were reluctant for them to continue when they would be out in the public. Are you still seeing a reluctance on the part of your patients to take part in physical therapy at a center or aqua therapy?
Yeah, we still are facing that challenge. And part of, I think, the reason for some patients now that some of the mask mandates have been lifted in different states and there's not really a lot of physical distancing happening in some places that, for good reasons, our patients are concerned. And what I've tried to encourage those patients that are, more fearful is like, well, okay, are you fully vaccinated, boosted? It's okay to wear a mask if you're going to a place that's more densely populated. Hand hygiene is, very important as well, and try to have physical distancing as much as possible. And I've gone as far as reaching out to facilities where there's been concern about some of these factors not being put into place and have asked for our particular patient, can these things be implemented, or is it okay for them to be a little bit apart from the next person doing physical therapy? But yeah, we certainly have people that are concerned. I will mention, though, there are a lot of things that can be done at home. So we encourage people to Google, let's say, doing Pilates or yoga for MS. And so there's still a lot of things people can do at home or walk around your neighborhood if you're able-bodied. But there are still many concerns.
Yeah, I'm finding a lot of reluctance on the part of my patients to get out of their homes. Some people are still almost homebound, after 2.5 years, just about.
Well, can I ask you a question? How are you approaching a patient that is very fearful and has become essentially agoraphobic?
So I actually had one this week. It was a person who pre-pandemic, first of all, she's in her 70s, and pre-pandemic, she loved to travel, and she traveled to Europe and all sorts of places 2 or 3 times a year. So she hasn't been anywhere since. And I, pointed out to her, that she does have some risks of having a worse case of COVID, but she's fully vaccinated, and I encourage her to get vaccinated every time it's available to her, and I'm sure she will. But I also pointed out to her that we have effective treatments, and I'm sure you'll probably get into this as well. I mean, if somebody gets COVID-19 and they're at high risk, even just due to age, we have things we can do. And I encouraged her to contact me and contact her primary doctor, anybody she can get if she gets COVID. And I also keep telling people they need to test themselves frequently if they have new symptoms, just to make sure they don't have it. And if they do, then they need to let some clinician know so they can be treated.
Yeah, so it's sort of trying to paint a brighter picture, I think, for the person that is very fearful. And I worry about the mental health aspect of COVID and how it's impacted our patients and obviously all of us, right? And so I think for some patients where I'm seeing that they're really in a bad place from a mental health perspective. You have to weigh the risk and benefits. What is the risk of getting COVID versus the risk of being in a really bad place of mental health or worse mental health than they already are. And I've tried to, talk to patients about that and say, well, your mental health is incredibly important. And so getting out of the house once in a while is really going to be beneficial, not only for your mobility and getting out there, but also mental health.
Totally agree with you on that, Scott. I also tell my patients to get themselves a set of good masks, usually KN95s that fit well. And I show them how you can fit it to your face and blow out, and you shouldn't have your eyeglasses fogging up or feel the breath coming out of the sides. And if they don't, they've got a good fit, and then to go on with their lives. But again, many people, not just our patients, but many people are fearful. So do you recommend all of your patients or some of your patients to get the antivirals if they should come down with COVID-19?
So this is a work in process with my own mind. I'm still trying to figure out, does everyone need like Paxlovid, for example? So I have recommended it. I think what's challenging for me to sort out is who are those patients that really are going to be in a bad place, if they get COVID, especially now that, we have Omicron, which for all intents and purposes, it seems to be less lethal than maybe Delta, but more contagious. So this is sort of a partnership. And you had mentioned reaching out to a clinician, reaching out to a primary care provider. So I've made it in my clinic to where the patient will reach out to me and then also their primary care physician. And it's a collective decision, I think, amongst all of us. And I think for those patients that certainly have higher risk factors, I have been recommending it, and also the monoclonal antibody that's being used. If it's someone, let's say young, otherwise healthy, maybe on a less effective or less potent disease-modifying therapy and has no other comorbidities, in that situation, maybe they don't necessarily need to go on any of the treatments, especially as we learn more about the rebound that may occur with Paxlovid, which I'm still trying to wrap around my head. But for those that are higher risk, absolutely. I think I do recommend doing the antiviral. And then, if they're a candidate for the monoclonal antibody, then doing that.
Yeah, I totally agree. I mean, obviously, Paxlovid has its issues with drug interactions and that sort of thing. And also, I've had now a couple of patients that just could not take it. They were nauseated and vomiting and, had to stop it short. But
can I ask you a question about that patient where they're having tolerability issues? Have you told them to take like half the dose or, just try to get a few days in? I mean, there's no scientific, I guess, guidance, but just curious.
No, I haven't, because I don't know if half dose will work in individual cases. And usually they're so bothered by it that probably half dose won't work for them. They'll still have to stop it. If they can only take it for a day or so, then I'll try to get them bebtelovimab, which is the current monoclonal antibody that acts against Omicron, or remdesivir, but that's a big logistical challenge because it's outpatient for 3 days, used off-label, and it's IV. So it means a person has to get to an infusion site 3 days in a row and get an IV in and be infused. And that's typically, at least for my patients, a difficult thing. I'm pretty liberal with my use of Paxlovid these days, after looking at their other medications and making sure there aren't any big interactions. So I probably have given it to some people that maybe didn't need it, but I'm trying to err on the side of caution here. So have you used any preemptive treatments in any of your patients, and which ones?
Yeah, so Evusheld probably has been the number one. The typical person that I've recommended to get Evusheld are those that are on B-cell depletion and S1P modulators. Reason being is, there, I think, is a wealth of data now showing that those patients, not only, at least some of them at higher risk to have bad outcomes with COVID in general, but then also the vaccine response. So COVID-19 vaccine response is blunted with people on those medications. And so Evusheld is, I think, a nice way to try to help mount up at least some antibodies within the body that if someone were to be exposed to COVID or get COVID, maybe they won't be as severely affected.
I do exactly like you're doing. I'm giving it to the people on the sphingosine 1 phosphate receptor modulators, as well as people on any B-cell depleting agent, or at least offering it to them. Not everyone has accepted, but those who have, I think, are happy that they did and are now mostly coming back for their 6-month retreatment. So what do you recommend to women, since we have a lot of women with MS in the childbearing age range? What do you recommend to them regarding pregnancy and breastfeeding and that sort of thing in this age of the COVID-19?
Yeah, no, I can say until recently, and you were involved in one of these initiatives, the only initiative that I'm aware of, the COVID-MS registry, showing that our patients who are pregnant, who get COVID, that there seems to not be a worse outcome versus, those that may not be pregnant. And then similarly, the postpartum period. But I would say before that publication, we'd have, I think, conversations around, well, geez, we don't really know. If you get pregnant and you get COVID, based on the general population data that's out there, it could affect you in a greater way than not being pregnant. But I think it comes down to a shared decision making. We have a lot of our patients are young, otherwise healthy women in childbearing ages. We've continued to, I think, endorse getting pregnant if someone is interested in getting pregnant. But I think now with the data that is from that recent publication, from, again, the COVID-MS registry, it makes me feel a little bit better that we can say to our patients, at least based on this one study, one registry, that getting pregnant, if you get COVID, then there may be not as a dramatic impact on you versus a general population. But I mean, all hands on deck. If someone's pregnant, they get COVID, they need to let everyone know, because they could get into trouble, and we want to make sure that we do right by the future mom and baby.
Yeah, I totally agree. And you, of course, Scott, were also involved in that publication that I don't think is quite out yet, but will be out in MS and related disorders soon. So, yeah, and we didn't have that many people, as you know, that were pregnant or postpartum in that registry, but certainly no indication of bad outcomes. Have you noticed, or are you aware of any data that MS is coming on de novo in people after having COVID-19, or that COVID-19 is causing true relapses in people with MS?
Yeah, this is a hot topic. Every clinic I have, this comes up, and including, if I get vaccinated, will it, cause my MS to get worse, or will I have a relapse? So I know there are case reports that are suggesting, maybe someone developed MS after COVID-19 or after getting vaccinated. But I think if we look at the totality of the data that's out there, and then if we look in our individual clinics, my view is that I don't feel that either of those two things, COVID-19 itself or the vaccine, are causing MS. I feel like it's unmasking probably someone who's already predisposed, just like we've seen in years past with other infections and vaccines. More commonly that we're seeing in someone who has MS already is pseudo relapses. So we do see people's baseline MS symptoms amplify a bit, could last for, a few days, and then usually goes away. I have not seen relapses, though. I mean, I've heard of colleagues where they've had some patients where they say, absolutely, they've had a relapse or a new spot in MRI that was enhancing post-COVID. But I think those are far and few between cases, and too few cases in my mind where I'm not going to recommend, not getting vaccinated, for example. We're going to say, no, you get vaccinated, protect yourself and others as best as you can.
So you, Scott, wrote a first authored paper dealing with the COVID-MS registry, and particularly focused on diseases, a couple of diseases that can mimic MS, neuromyelitis optica spectrum disorder and myelin oligodendrocyte glycoprotein antibody disease. And I'm just wondering if you can share with us the results of that study.
We were very interested in looking beyond MS. I think for the audience, other diseases we treat that mimic MS, often we use similar medications that suppress the immune system. And, there are autoimmune conditions that sometimes affect the person even in a greater way than MS. And so we had very similar questions. Does the underlying disease itself put them at greater risk to contract COVID or to have more severe outcomes? And then further, the medication that the person may be on, Does that influence the severity of COVID-19? And are there other factors? So sort of the Cliff Notes version of it, and you were involved in this as well, is that you have to be cautious. The sample sizes were small. We had a little over 70 patients who had NMOSD and only 20 who had MOGAD. But those that had NMOSD, what we found really was that coexisting medical comorbidities like obesity, diabetes, for example, seem to be what puts someone at the greatest risk to have more severe COVID outcomes. So not just NMO, but NMO plus the medical comorbidity. Now, when we look at medications, the challenge is, number one, sample size. And most of the people who had NMOSD were on rituximab, so B-cell depleting therapy. So there, it's hard to know whether the drug itself causes more severe outcome in that patient population. But I think if we leverage MS as sort of a poster child for this, I would personally feel that, yes, it probably puts someone at greater risk. If you have NMO, you have multiple comorbidities, and you're on rituximab or another B-cell depleting therapy. Those are the people I'm very concerned about. In public health preventative measures, mask when appropriate, physical distancing, hand hygiene, get vaccinated, Evusheld. That's sort of my process. And then MOGAD patients, we didn't see any major factor that put them at greater risk for severe outcomes, but sample size, I think, is the reason for that.
Great. Thank you very much for doing that study so that we can have some guidance on treating those patients too. Today, we've talked about COVID-19 and multiple sclerosis. Thank you so much for joining us. Thank you, Scott, for spending some time with me and going through this. And this is Dr. Ann Cross for In Discussion.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple sclerosis.